So here I can see that there are the small amount of ascites is seen with misty or fat stranding is seen within the mesentery. There is also soft tissue thickening is seen, which is increasing the mesenteric vessels. There is significant fat stranding and thickening is seen involving the omentum. And there is also enhancement of the peritoneum is seen at places. I can see that there is extravasation of the contrast is seen around the urinary bladder. Along with there are multiple fractures are seen, which is involving the pelvic bones. So I'm just going till the last cut, then I will again describe. Okay, so it's a little bit lagging. So I'm just trying to go to the area of interest. So here I can see that there is comminuted fracture is seen, which is involving the anterior pillar of the right acetabulum. And
Can you point
patient
that
is
out? All right.
this
What
one, sir.
else?
So I'm going to check further fractures if there is any further fracture is seen, which is involving the pelvic.
You've been given the soft tissue window. Don't you think you should be commenting on soft tissues first?
Okay. So here I can see that there is significant contrast extravasation is seen with around the urinary bladder, and there is, however, the urinary bladder is catheterized. There is also it is giving it a molar tooth appearances. So this is extra extraperitoneal bladder rupture. So I'm also going up to again check further viscera for the presence of any further um, so I'm just going to check the kidneys, and I can also see that there are prominent gut loops are seen. So I will further evaluate on coronal images.
Okay, so you say this is extraperitoneal. Why do you think it is not intraperitoneal?
Yes, here I can see these are vessels rather. So I cannot see any contrast extravasation within the bowel loop. So that's why I'm expecting that this is extraperitoneal. Here I can see that the left ureter is also distended, and I'm just again check whether it is. So in between, I cannot see the ureter. So this is just proximal dilatation. So I'm suspecting involvement of the left ureter, and I also check the rest of the viscera. Looking at the pancreas.
Yeah, the other viscera were fine.
Okay. So in summary, the findings are of I'm suspecting left ureter rupture and urinary bladder rupture. So I immediately convey the finding to the referring physician. In my routine practice, I'll also check the bone window and coronal images to so I'm checking the whole of the lumbar spine for the presence of any fracture which is involving the lumbar vertebrae. So there is also fracture is seen, which is involving the left iliac blade. It is involving the inner cortex with depressed fracture. and both the sacroiliac joints appear normal, and I'm looking at the pubic rami and ischium. So there is no further fracture which is involving the rest of the bone. So
Except
immediately
for the left iliac bone fracture, you said there are no other fractures. You did talk about some fractures in the acetabulum earlier.
yeah, including like right acetabulum and left iliac bone. There is no further fracture of the visualized bones.
Okay. Can you stop
So
using your mouse?
okay. So I will convey the finding immediately to the.
We have the fractures of the pubic rami bilaterally too. There
Okay.
you go, and there you go.
Okay.
So, what would you do next?
So immediately convey the finding to the referring physician, and a surgical team and urological consultation is suggested. However, the extra peritoneal bladder need conservative management and orthopedic consultation for fractures management.
And can you tell me the classification of bladder injury?
Sir, I remember intra and extra bladder ruptures.
5 types.
No, sir, I cannot recall right now.
All right. There you go.
Okay. So I have been presented with axial T2 images of the pelvis. So first of all, I'm going through the images. I'm just looking at the pelvic viscera. There is soft tissue. Uterus appears unremarkable, and there are soft tissue density seen, which is involving the both right adnexa.
Just the right adnexa.
Yeah, it is also on the left adnexa. So they are of intermediate signal intensity with few high signal intensity areas all seen in the surrounding peripherally. So in my routine practice, I'll further evaluate this on T1 images to look for presence of further characterize these lesions, and the rest of the
To look for the presence of?
to further characterize this lesion, whether there is an
Okay.
hemorrhage.
Just stop scrolling for a bit. There you go. This, I guess, is T1. Yeah. Please scroll.
So these areas appear low on hypointense on T1. Heterogeneously hypointense on T1. So there is no high signal to suggest hemorrhage within this adnexa. On the left side,
But there is subtle hyperintense signal, don't you think?
on left side, there is a subtle hyperintense signal, which is just peripheral and central low intensity to suggest just peripheral margins. So I'm further want to check this on post contrast images.
Why do you need a post contrast for this sequence for this case?
Just to
What do
check
you
the
want to
enhancement.
evaluate on?
Just want to, sorry, ji sir.
What do you want to evaluate on post contrast sequence?
So I just want to check whether there is any ovarian torsion, or these are just enhancing masses. So, or also check fat chat images to look for the presence of any
Please scroll.
Okay. So on post-contrast images, we can see that there are multiple multi-septated bilateral adnexal lesions, which is most likely the left side, as it is showing heterogeneous peripheral septal enhancement. On the same bilaterally, rather, it is showing peripheral enhancement. I'm just trying to look for the presence of any pedicle twist to just check. So there is no torsion. I'm suspecting a bilateral adnexal multiseparated lesions. So if the patient is a known case of any primary cancer, these may represent bilateral metastatic ovarian masses. Other possibility could be um, just any um, like benign etiology, which is less likely.
Like what?
Um, hemorrhagic, bilateral hemorrhagic cyst, which is less likely, as I cannot see any high signal or
The
T1.
patient is a young patient, and she's not a known case of any primary tumor.
Okay, so these may represent then, as I can see, incomplete septa. So these may represent in a tuberovarian abscesses. If the patient
Any
have
other
any history
sequence
of
that will help you
inflammatory
out?
uh, fat set or diffusion weighted,
This is fat side T1 post contrast. You
yeah,
need diffusion weighted sequences. Yeah.
yeah,
Just stop scrolling for a bit. Please scroll.
okay. So I've been provided with the WI and ADC. Um, so I cannot see any yeah, so there are high signal areas which is involving the both adnexal lesions. So with more heterogeneous areas of diffusion
Correlated
distribution.
with the ATC sequence too.
So it is low on ADC and high on DWI. So this suggests abscesses, which is involving the tuberovarian region, or yeah. So immediately convey the finding to the referring physician, and further gynecological consultation is suggested in this case for further management.
Gynecological management would be.
As these are tuberovarian abscesses, so patient may be given first antibiotic cover, and then if they remain, if it does not resolve, so then further um, in drainage may be suggested.
Okay. Well done on both the cases, Dr. Saab. With the first case, now you need to stop scrolling. With the first case, let me just share the first case again.
May I just give up the remote?
Yeah, please, if you can. Thank you.
Thank you.
Yeah, with the first case, there was a little bit of mistake that you made initially. You were given the soft tissue window, yeah? And you
Okay.
started commenting on bones first. For bones, you have to comment on it. Of course, the pelvic fractures were very important in this case. But first, you should have completed all the soft tissue findings and then asked for a bone window rather than commenting on bones on the soft tissue window. This is a very rookie mistake, but needs not to be done. Okay.
Okay.
Other than that, there were fractures of the pelvic rami too, here and here, which you were not able to identify, but the rest of the identification, the description was quite good. This was a case of extraperitoneal bladder rupture. So I've given you a clear pass in observation. With the knowledge, you did not tell me the classification. Yeah, there are five types. that you need to read up.
Okay.
One is type 1 is bladder contusion, type 2 is intraperitoneal bladder rupture, type 3 is interstitial injury, 4 is extraperitoneal, and 5 is combined. So I'd still give you just pass in knowledge too, since you did have the basic idea of intra and extraperitoneal bladder rupture. Your clinical reasoning was good, so you're quite good with that. Clear pass in that. Your management was also very good, clear pass, and I'll give you pass on communication. So overall, this case would be pass for you. And then
Thank you, sir.
uh, with the second case, now see, so there was a little bit of hesitancy with this case. You see all this inflammatory masses bilaterally. I don't think you should have spoken about a neoplastic disease first, although the appearances could be similar, but there is more of inflammatory reaction going on in both the adnexus. And then did show you the diffusion weighted, there was diffusion restriction, and on post contrast sequence, you see bilateral tuber ovarian abscess. There is peripheral enhancement with internal enhancing septation, surrounding inflammatory changes. So this was a case of tuber ovarian abscesses. So with the observation, I'll give you between clear pass, just pass. Your knowledge was good here also. With the clinical reasoning, the clinical safety and communication, you were able to tell me about what you need to do next. These are generally treated with surgical drainage. And on communication, I'll give you a pass. So well done on both the cases. From my side, this is pass on both the cases.
Mm.
Yeah.
Thank you, sir.
Yes, very
Thank
good
you.
attempt, candidate one. I just need to add something. Ma'am, you just,
Yeah.
you need to be a bit, faster. Your speed was a bit lag. There was a bit lag in your speed that I found. You have to sound more confident, and your preparation is very good. So, just practice the Viva and just try to be a little bit quicker. Otherwise, you will okay.
Thank you, sir.
Can you see my screen?
Yes, I can.
Okay, yes, you may start now.
Okay, so I'm presented with frontal radiograph of the pelvis of a skeletally mature patient. You can see that there is an abnormality involving the right inferior pubic ramus in form of leucent or lytic lesion with cortical breach. The lesion shows wide zone of transition associated with very subtle periosteal reaction. There is no internal matrix. The head of the right femur is intact. However, there is associated degenerative changes. The rest of the bones show no additional focal lesion. The bowel gas distribution is non-specific. So I'm so much concerned about destructive lesion in this adult patient. My top differential is metastatic process. I would like to compare with any previous imaging is available or any other relevant images. I would like to correlate with the patient's history for any non-primary disease. I would like to urgently convey my finding to the referring doctor. Proceed for CT scan of the abdomen and pelvis, looking for any primary, doing MRI for this lesion for further characterization.
Just
Okay.
ask for the control.
Okay. Requested.
Okay, go ahead.
Okay, so this is the MRI for the same patient. I would like to have a look, general look before starting my comments. Okay. So this is a fat sensitive sequence T2.
Is this fat sensitive sequence?
Yes, I can see the fat. It's not fat suppression, it is T2.
Be very careful with the sequence, okay?
Okay.
Mm.
Okay, so yes, I'm looking for the area of concern seen on the X-ray. It was on the right inferior pubic ramus. So yes, this is the area of concern. It shows increased size of the bone with heterogeneous signal intensity involving the region of the medulla appearing hyperintense on this T2. Yes, I would like to check for any evidence of cortical breach or associated soft tissue mass, which I can see. And yes, there is. I would like to check for any other similar lesion. in these given images, which I can't see. I would like to check for any associated lesions like lymph nodes
Okay,
or
just wait a second. Just
extension
wait a
to the
second. Wait a
nearby
second.
structures.
Wait, just
Okay.
wait a second. Okay. Identify the sequence and then tell me the findings.
Okay, so this is fat suppression, and it is FLAIR.
Layer, fat suppression. Okay.
Okay, so yes, the region of concern.
Do you want to add
is-
anything into your findings?
Okay. Okay. Yes, there is yes, the lesion appears hyper intense on this flare.
Any other lesion beside this? Just leave this lesion. Any other thing?
Okay. Mhm.
If not, then
In
conclude the
fact,
case. Then conclude the case for me. If not, okay. Any other lesion beside this lesion?
okay. I'm just looking for the rest of the scan. Okay. To me, no definitive additional lesions could be identified.
Okay. Can
Yes,
you?
yes, yes. There is one lesion on the left iliac bone.
Okay.
Okay, so
So conclude the case for me.
multiple bony lesions, destructive
Hmm.
bony lesions,
Hmm.
highly suspicious for metastatic bone deposits. I would
Hmm.
like to, yes, convey my finding, do malignancy workup, refer to MDT, oncology MDT meeting,
Hmm.
image-guided biopsy, histopathology, and staging.
And what imaging workup will you advise?
Uh, Imaging workup, it is CT CAP, CT chest, abdomen, pelvis with contrast.
Hmm.
We look for the
Hmm.
primary.
Okay. And what is the most common cause of a metastatic deposit in an elderly female? She's a 70-year-old female. So what will
Okay,
be
so I would be concerned about the breast primary, so mammography should be included
mammography?
on the, yes, on the management plan.
Okay. Okay. Okay, good. So this was your first case, and now I'll show you the next case.
So I'm presented with axial CT scan of the abdomen with IV contrast. I would like to have a general look before starting my comments. It's just going quickly. So starting from the uppercuts going down.
You see, I have deliberately put in the thickened cuts because in exam, they used to put thick cuts which are going to scroll very quickly. So just be patient in while you are scrolling, okay?
Okay, so starting from this cut, I can see there is marked bowel dilatation seen on the periphery of the abdomen, denoting large bowel obstruction. You would like to check the rest of the bowel loops to look for any obstructive lesion and to look for the point of transition. So, um, yes, I can see there is a swelling sign over here. So I'm so much concerned about this obstruction being a valvulus, and the orientation, the location, and the appearance is suggestive of sigmoid volvulus. I would
Mm-hmm.
like to check for any signs of ischemia. There is no pneumatosis intestinalis. There is no free intraperitoneal air. I would like to further confirm this on the lung window. There is, I would like to check, yes, thank you. So, again, no pneumatosis, no pneumoperitoneum. I would like to check the free gas in the portal veins in the liver, which I cannot see. So in my routine practice, I will check the rest of the scan, rest of the solid organs and the vessels to check the patency of the vessels. I would like to check the lung window and the bone window. The lungs is clear. I will check,
Don't
yes.
repeat these findings again. Now, what will be your next step?
Okay, so this is, and I will take the coronal as well. So in my routine, this is urgent. I would like to urgently convey the finding to the referring doctor and to the general surgery team. A rectal tube should be inserted to try to detort this volvulus and to, yes, follow the patient.
Okay, very good, very good. So you are done with your both of the cases, and it. Let me give you the feedback. Okay. Very good, Dr. Nagam. Just keep it up. Your pace is excellent. This is how you should be, going with the pace in the exam. And regarding the scoring, you were in the first case, you were clear pass in all components. In observation, I would have given you excellent if you could have picked up those lesions without my prompt. Otherwise, you're a clear pass in all components. And in communication, you were excellent. And in the other case, I guess again you were clear pass in all components. In communication and observation, I have given you excellent. So keep it up. Do practice daily, and you are going in a very right direction. Okay. Thank you.
Thank you so much, Dr. Amir. Thank you.
Okay. So next candidate, Dr. Shah, over to you.
Yeah, thank you very much. This second candidate, I think she was brilliant. She did have knowledge of how at what pace she has to go. She was very quick in picking up
Hmm.
the findings. She was very
Hmm.
quick in explaining it all, except for
Hmm.
that one metastatic deposit which she did pick
Hmm.
up
Hmm.
after a few prompts. But other than that, I think she was brilliant.
So I have been presented with the city abdomen axial section post-contrast sequence. First, I will scroll through the image and then I would like to comment. The most striking abnormality, first of all, I can appreciate that in the IVC, there is a large filling defect. I'm now trying to scroll down to first see the whole of the stack of the images, and then I would like to comment further. I'm going to the top again. I can see that urinary bladder is fine. Rectum is overloaded. I can see this is uterus is enlarged with central fluid. Apart from this, I can see on the right adnexa, there is some collection noted, which is a little peripherally enhancing. I can see that this collection is also continuous along the right side of the abdomen. I'm further moving up. I can see that this filling defect in the IVC is a thrombus. And I can see that this thrombus within the IVC. And apart from that, the right and the left renal veins emanating from the IVC are fine. No thrombus noted within it. I can see anterior to the IVC, there is another low density area noted, which is peripherally enhancing. And I can see that this thrombus is further going down into the bilateral bifurcation of the IVC. And this collection, which is noted along the right adnexa, which is peripherally enhancing, is continuous with that. So I believe that this is the right ovarian vein in communication with that collection. And the thrombus is emanating from that collection into the bilateral branches of the IVC and up into the bilateral common iliac veins and into the main iliac vein. I would further comment on the other visceras. I'm trying to go up.
The other visceras were fine. What do you think is going on?
As I can see that the uterus is also enlarged with some endometrial fluid, and also there's the right adnexal collection noted here. I would like to first of all correlate with the history of the patient, is if the patient has any postpartum history, recent fever or some infection process going on. So the first most thing I would like to comment that this is likely abscess which is in the right adnexa, and as a result of it there is thrombus in the right ovarian vein, which is also dilated, and also the right into the IVC. And I would immediately inform the surgical on-call surgical team and refer this patient for the thrombectomy or the for the removal of this thrombus, and the patient should be on the anticoagulation. And I would also like to correlate with any previous imaging if available, or any postpartum history or the gynecological history of the patient. And yes, sir.
Okay. Granted.
I have been presented with, yes, sir. Yes, now I can scroll. I have been presented with the CT scan axial section of the abdomen soft tissue window, in which post-contrast sequence. I can see, first of all, the no striking abnormality, which I can appreciate is the arterially enhancing lesions within the liver, right and the left lobe. I would like to go to that section again. Yes, I can see that there are multiple arterially enhancing lesions with central non-enhancing area as well in both the right and the left lobe of the liver. I'm further seeing all the other sequences. The lesions have peripheral enhancement. I can see that there are other peripherally enhancing lesions with central necrosis located in the periportal location along the head of the pancreas. I'm trying to go further down. I'm sorry, it's a little lagging, and it's
Now it's the portovenous phase, okay?
sir. I can see in the portovenous phase the same lesions have the peripheral nodular enhancement, which is similar to the blood pool phase of the aorta, and some of the previously fully enhancing lesions are now the same. Also, the lesion in the periportal location is of the same intensity as that of the blood pool of the aorta.
So what do you think is going on?
I believe the lesions within the liver with peripheral enhancement and peripheral discontinuous nodular enhancement are having the same intensity as that of the blood pool and equilibrium with that. I believe that these are hemangiomas, but I'm concerned about the lesion which is in the periportal location. I would like to see that again. And maybe these are the other DD that differential that can be is the arterially enhancing metastatic lesions, but they should have washed out in the portovenous phase. So
Don't
my
you think
first
there is some washout?
No, sir. I believe they are of the same intensity. It is not hypodense on the portovenous phase.
All right, what are you going to do next?
I would like to correlate with the history of the patient, and as these are multiple hemangiomas, I would also like to see the liver, the lungs, if there are any other hemangiomas are present there as well, and also I would inform the gastroenterologist referral to the hepatobiliary MDT and also the gastroenterology referral, and also
How would you explain the
I
lesion in
would
the periportal region that you talked about?
yes sir. That can also be one of the metastatic lesion.
But you're talking about
And
hemangiomas, aren't you? Do hemangiomas
yeah,
metastasize?
sir, the other differential is it can be the arterially enhancing metastasis. Second, so it can be primary with mets in the liver, which are arterially enhancing, and
So your
it can be a
next step would
neuroendocrine tumor.
be, okay,
Mhm.
your next step would be to inform the gastroenterology team, as these are hemangiomas, you would want to keep it on a follow-up.
Yes, sir. And also, I would like to correlate with the tumor markers of the patient, and also I would like to discuss this case in the
See,
MDT.
you're swinging between a benign lesion and a malignant lesion, which is going to
Mhm.
be a problem for the clinicians.
Right, sir.
So you're not sure if these are benign or these are malignant. In your real life, there can be certain cases in which you're not sure either they're benign or malignant, but this is a clear-cut thing. You should be able to differentiate between the two.
I would like to advise the MRI,
And how
and
would that
also
help?
I believe that this periportal lesion is a sir. I believe that these are all the lesions are the
How
malignant.
would an MRI help?
You're right, sir. Uh, It
If
would.
you had to confirm if these were hemangiomas, ask for a delayed image, a delayed sequence. Why go for an MRI in this case? See, NHS is pretty much concerned about reserving their resources. They do not want you to advise extra investigations which really are not going to help the patient out, and they're only going to put burden on their already, tough medical services. This is it. We'll start with this case. Your feedback. Dr. Saab, with the observation, I'm afraid I'm going to give you, uh, mm, I don't know,
Borderline
I
fail.
don't know the terminology, but poor, I guess.
Hmm.
Yeah.
Mhm.
Why? Because there was an important thing that you had to identify in this case, which was uh, the left kidney, which is not there. And instead there were surgical staples. Can you appreciate the surgical staples here?
Yes, sir. Now I can. Yes. So these were all
So now
meds.
what do you think? So
Yes.
yeah, so what do you think the whole process is? It's a
It's
metastatic
RCC
disease
meds,
process.
arterially enhancing.
Yeah,
Yes.
it's arterially enhancing meds from RCC. The most common tumor, I'm talking about pancreas only. What are the most common tumors to metastasize to pancreas?
Sir, kidney first of all, and then it
Renal
could be
cell
liver.
carcinoma is the
Yes, sir.
most likely tumor to metastasize to pancreas. There was this one pancreatic metastatic deposit. There was other, the left kidney was not there, and then you had multiple arterially enhancing lesions in the liver too. So how do you think you did on this case?
Not good.
Not good.
Okay,
So
I just need to add something, Dr. Sabha.
yeah.
Whenever you see multifocal lesions, your top differential should be METs, and then try to look. And these are again hypervascular arterialized lesions, so you should be looking, and don't worry, this is just a practice forum. You can make as many as mistakes you can, but just try to improve your observational skills. When you have spotted multiple focal lesions, then your top differential should be metastasis, and then you should be looking for again all the organs and pancreas and gallbladder and kidneys. So okay, don't worry,
Right, sir.
but just try to focus on these points.
Yeah, so just because you went the other way, the whole management changed, the
Uh,
clinical reasoning
and I'm sorry to
changed.
say this was a critical mistake. If you do this in exam, they might mark you zero in all components.
Mm-hmm.
Okay?
Right,
Yeah.
right.
So
So
yes.
don't worry about it. You just need to
Mm.
practice. I'm sure in your office when you're sitting, you would very easily be able to identify this lesion. You'll be able to identify the whole scenario. It's just about the exam pressure, and this is where you have to practice. Use every platform to practice your Viva skills. That is going to help. The best thing that you can do to yourself to practice your Viva is participating in as many sessions as possible. So just don't worry. So this would be a failed case from my side. Your first case, let me go back there. And I think you were a clear pass on this one. Okay. Okay, can
Right,
you all
sir.
see my screen? Yeah. So this
Yes,
was an
yes.
enlarged ovary, and then you had these two structures. Can you see the two structures? One is this, and the other one is this. So this is the inferior vena cava, and this is the right ovarian or gonadal vein. You can see it draining into the right into the IVC, and from there the thrombus is traveling into the IVC. The thrombus will not travel from renal vein into the IVC. On the other side that you were seeing was the thrombus in the left ovarian vein. It wasn't in the IVC. Can you appreciate it here?
Yes, sir. Now I can. Yes.
Yeah, this draining into the left renal vein. See,
Yes, sir.
can you appreciate it? So this was
Yes, sir.
bilateral ovarian vein thrombosis. Just a little bit of lack of observation here too. I would give you a just pass on this one. Your knowledge was quite good on this. You were a clear pass in knowledge here. Your clinical reasoning was good also, clear pass in that too. Your safety management was also good. You wanted the patient to have immediate anticoagulation. Remember, if IVC is involved in ovarian vein thrombosis, you treat it as the same protocol as pulmonary embolism. Always remember that. So you did
Right,
well
sir.
on this case. So this was a clear pass from my side on this case. So one case, just because of the lack of observation, you did not manage to pass, but the other was a clear pass from my side. Well done. Just practice,
Thank you, sir.
practice. Don't worry. Keep
Yes,
keep
and your
making
communication was
mistakes
also
here.
good. Your
Yeah, her
communication was
communication
also
was
good.
also very good. Yeah, just
Yeah.
keep making. I would suggest you to keep making mistakes in these sessions so that you don't make the same mistakes in the exam.
In
Yeah.
the exam, yes, exactly.
Thank you, sir. Thank
All
you,
the
sir.
very best, Dr. And now we move on to Dr. Umair for our last candidate.
Okay.
Okay. This is the X-ray pelvis in the femur of a pediatric age group patient. I can appreciate that the patient is slightly tilted towards the right side. It could be positional. Um, Other than that, I'm first trying to look at the femoral epiphysis, and these look in its normal expected locations. And the other than that, uh, the rest of the bones, I'm trying to look at the rest of the bones. The iliac bones appear normal. The femurs, these appear normal. In my normal practice, I would like to zoom a bit, and would also like to review the frog-leg lateral view,
Mhm.
um, to look for if the any other pathology. Um, and on this, the right, sorry, the left femoral head. Um, wait.
Both the femoral heads are
Yeah,
fine.
yeah. It's fine.
Okay.
It's just positional. Yeah.
Anything
So,
else? Anything else?
um, yeah.
Okay, so tell me one thing. If I
Also,
present and if I X-ray is presented to you like this one,
I will. Yeah.
except bones,
Uh,
what are you going to look? Except bones.
Except bones, I would look at the soft tissues. I would look at the
Mhm.
bowel. I would look at the
So
hernial
have you seen the soft
orifices.
tissue? Okay. Okay. Have you compared the soft tissues on both sides in this case? Any difference? Or they're the
Um,
same?
the soft tissues on the right side appear more denser,
Mm-hmm.
um, predominantly along the lateral aspect of the right femur.
Mm-hmm.
There are uh, few radiopeg density. These are likely these densities look like artifactual, but yeah, there is a soft tissue increased density
Discrepancy.
producing bulge. Yeah,
Hmm.
so I would like to evaluate this further with MRI.
Okay. Okay, this is
Okay.
the MRI of the same patient. So, okay, before scrolling, what were your differential on the plain radiograph?
On the plain radiograph, in a child, my differentials would include E-wings,
Hmm.
as it predominantly was involving the shaft. Other would
Hmm.
include a Langerhans histiocytosis, and if patient has history of fever, osteomyelitis
Hmm.
can also be a differential.
Okay, okay, now start scrolling, please.
Okay, these are axial. These are MRI axial T T2 weighted images.
Yes, T2
Um,
images.
so I can appreciate that there is an long segment abnormal signal intensity area seen involving the left thigh muscles. Um, and there are also patchy abnormal signals also seen within the patchy marrow abnormal signals also seen within the left femur.
Hmm.
It appears heterogeneous. There is, yeah, at this region, there is a cortical irregularity with area of a cortical break along the anterior aspect.
Hmm.
Uh, at, okay, at the anterior aspect, now I'm again going to the area of interest at the cortical break at the anterior aspect, and
Any other
with
sequence
a
you want to
mass
see?
extending. Yeah,
Hmm?
I would also like to review the T1 weighted images and the yeah.
Identify the sequence
So
and start scrolling. Which sequence is this?
this this is fat set. Uh,
That sets plain or post
yeah,
contrast?
this is a fat set post contrast image.
Okay. Okay.
I
So what do
can
you see on this?
appreciate. Yeah, I can appreciate that this area shows a peripheral post-contrast enhancement, predominantly peripheral post-contrast enhancement, um, with the yeah, and with subtle patchy marrow signal abnormality also seen within the femur, with the
Hmm.
adjacent soft tissue component, which shows a patchy peripheral enhancement.
Okay.
So
So what is this representing? This patchy
this
signal, marrow edema, what is this representing?
this represented this is likely this is a bony lesion, aggressive bony
Hmm.
lesion with the associated soft tissue component. So
Hmm.
in this age group, my first differential would be Ewing sarcoma with a large associated soft tissue component.
Hmm. And
And
what
I
about the
cannot see
enhancement
any
of this
sequestration.
component? Okay, what about the enhancement
It
of the
it
soft
is showing
tissue peripheral enhancement, right? You said
yeah,
that.
with a symptom. Yeah.
So still you will keep the Ewing sarcoma on the top. Any other sequence you want to see? Any other differential for this last soft tissue component you want to give?
It can be an as it is showing a peripheral enhancement, it can be an abscess
Okay,
or
what
yeah,
sequence next you want to see?
diffusion restriction.
Okay, okay, just wait a second. Okay, I'll show you the diffusion imaging. So this is the
Okay,
diffusion
so
weighted imaging. Sorry for the quality, but you can appreciate this is the
yeah,
DW
these,
and this
yeah,
is
I
the
can
AD.
appreciate that. There are areas. It is showing
So
diffusion
conclude the
restriction
case.
with
Now conclude the case
yeah.
for me, okay?
Yeah, so findings are likely suggestive of infective etiology with a large abscess with adjacent marrow signal, infective changes also involving the bone, osteomyelitis. So
Hmm.
I would immediately convey my findings to referring physician, and this patient needs interventional radiology referral for the drainage of the abscess as well as the orthopedic referral for the management and start of antibiotics.
Okay, good.
Okay, these are CT scan Excel section, a lung window. I can appreciate that there are patchy areas of ground glass haze seen involving the both lung field yeah, with inter and interlobular septal thickening,
Hmm.
um, giving interinterlobular septal thickening. I cannot appreciate any evidence of honeycombing within these sequences.
Hmm.
Yeah, there is no honeycombing is seen, so findings are likely suggestive of non specific interstitial pneumonia. And I can also appreciate the esophagus is markedly dilated. And in my normal practice, I would also look at the mediastinal window to look for the lymphadenopathy and the vascular. Okay, now I'm provided with the mediastinal window. I can appreciate that pulmonary trunk is normal in size. No significant lymphadenopathy seen. Esophagus is markedly dilated. Liver is of normal density, and spleen also appears normal. So, this is a case of non-specific interstitial pneumonia with mega esophagus, likely a case of scleroderma. And I would convey my
Hmm.
findings to a referring physician. And this patient needs a comparison with prior imaging and discussion in connective tissue MDT and a further evaluation with the barium swallow if patient has any history of dysphagia to confirm
Hmm.
this finding, and a further systematic workup including X-ray hands and to look for its finding, and CT abdomen to
What
look
are
for the
these patients prone in the abdomen?
they can develop there is usually they can cause the hidebound appearance of the bowel and
Hmm.
mega they can cause a dilatation of the small bowel loops. Yeah.
Hmm. Okay, and how will you manage this case?
Yeah, I would refer this patient to the connective tissue MDT and
Hmm.
for the discussion and
Hmm.
the comparison of the NSIP features with the prior imaging
Hmm.
and further management.
Okay, okay, good.
Steroids can be started.
Okay, okay, good. So that was all from my side. And you did very good in this case. And again, if whenever you saw a pattern of interstitial lung disease, there are four review areas, okay? Esophagus, pericardium, then liver to look for any, change in the density, to look for any amiodarone related issue. Then you have to comment upon the pleura for any calcification to rule out what? Asbestosis. Okay,
Asbestosis.
and also
Okay.
lateral end of the clavicles. Why you have to see the lateral end of the clavicles?
Erosion. It can cause a lateral clavicular erosion, scleroderma.
Which condition? Yes, scleroderma can cause the
Yeah.
erosion of the lateral ends of the clavicles. So yes, you were
Yes.
clear pass in that case. Also, you were good with the communication too. But you need to practice a lot. You were
Okay.
lagging a bit in
Mm.
the description. Otherwise, your knowledge in this case was good. And the safety and management, I will give you just pass because I have prompted you for the management. You have to tell it by yourself. In the observation, clear pass. In the clinical reason, clear pass. In the knowledge, again, clear pass. So that case you did very well. And the other case, now this one. Now, in this case, again, see. with the observation, I will going to give you borderline fail. Clinical reasoning was borderline fail. Knowledge was just pass, and safety and management was a clear pass. You know the exact management, and in communication, again, I'm going to mark you just pass. Okay, so beside the
Okay.
bones, you have to look for the discrepancy in the soft tissue. Look, see, see the
Yeah.
discrepancy. You have to mention it now.
Hmm.
You have to mention that, other, try practicing the review areas in the chest x-ray. In the pediatric x-rays can be very tricky. If you I mean miss such thing on a plain radiograph, they might fail you the whole of the case. Okay. So again,
Okay.
other than the bones, yes, you were thinking of the Sufi and other things. That was good. You were thinking of AVN. That was good. But the soft tissues should be in your mind. Okay, and then you have to comment
Hmm.
on these cortices that these are fine, and also again try to practice on the sequences of MRI. Okay, that which sequence
Hmm.
is this, and you have to identify quickly. You did well on that, and then again it was a large abscess with osteomyelitis, and that was all from my side. If Dr. Shah wants to add something.
With the case one, I thought was a little bit slow.
Hmm.
I think the knowledge is there, everything is there. She just needs to practice.
Hmm.
You need to practice. I
Yeah.
think you
Yeah.
have all it
Okay.
takes to pass the exam. Just practice as much as you can. This is
Hmm.
it from my
Hmm.
side.
Hmm.
Okay.
Yeah, so
Okay.
Thank you.
this was it for the day. Thank you very much, everyone, for attending this class.